Today I'm going to talk about controversies in the treatment of resistant Pseudomonas aeruginosa. Actually, this talk needs like a workshop rather than 20 minutes to talk, but I'll try to be I focus on clinically relevant issues. Okay, so my outlines, I'll have two parts. The first 10 minutes we'll talk quickly about resistant mechanism of Pseudomonas, MDR Pseudomonas in Saudi Arabia, and then susceptibility comparing EUCAS versus CLSI. The part two will be about the treatment difference between ECMID and IDSA, and some controversies and questions that I actually faced during clinical practice. So actually, my first question when I heard about difficult to treat Pseudomonas, that we already have a lot of definitions. Why we need to have like a difficult to treat resistant Pseudomonas? But then I actually like this definition, because once you hear that difficult to treat Pseudomonas, you know that you are facing an organism that is resistant to the first line agent. So you don't have to go through the categories, and so you by default, you know that you are dealing with Pseudomonas that is resistant to carbapenem, beta-lactam, specifically cefepime, ceftazidime, and fluoroquinolones. And if tested, tazocin plus aztreonam, okay? So it is under MDR, but then and some of the difficult to treat resistant will be banned, the drug resistant Pseudomonas, but it has some like I don't know if we can use. Okay. Can we go back to the slide, please? Okay. All right. Difficult to treat Pseudomonas, it's not like always XDR. Okay, so it's mainly a clinical definition. Once you hear about it, you just know that your organism is resistant to carbapenem, beta-lactam, and quinones, and aztreonam and tazocin if tested. So this is like an example. Our first, if you see the susceptibility pattern of the first organism, it is carbapenem-resistant Pseudomonas, but it's not difficult to treat. While the second one, it's resistant to the first-line agents, ceftazidime, cefepime, imipenem, meropenem, and ciprofloxacin. Okay, so quickly about resistant mechanism, I think it was covered in other talk. So Pseudomonas is a very unique organism. It's a nosocomial infection, and this tells you a lot about this organism, that it's easily become resistant to the available antibiotic. So in comparison to Enterobacterialis, it's mainly enzymatic production, and we have now genetic testing for Enterobacterialis, but this is not the case with Pseudomonas. So it has like a lot of mechanism resistant that include permeability mutant, mutation, multi-drug efflux pump, and or loss of outer membrane borines. And this is like kind of main mechanism of resistance to Pseudomonas. While some of Pseudomonas will have beta-lactamase mediated like chromosomal AMP-C, which is the most common, ESBL and carbapenemase. Testing for this and having a negative result will not totally exclude carbapenem-resistant organism. And this is why this is important in the clinical practice, because for screening for resistant, sometimes for now that we are using carba-R, for example, if we have an E. coli that carba-R negative, we think it's a susceptible organism. This is not applied in Pseudomonas, because we have another mechanism of resistance that can usually not detected by genetic, by the available genetic testing. So where do we stand? Do we have a lot of carbapenemase producing Pseudomonas in the region? This is a very interesting article about this. So if you can see the gray, so the color code, the gray is, okay. So the gray is that none of the carbapenemase genes identified, and compared to the colored, this is like the carbapenemase gene identified. If you can see that just M, NDM, and KPC. And very interesting, if you see that, like for the USA, for example, they have, sorry, cannot see. So for USA, for example, 98% of the isolate was they don't have the carbapenemase gene identified. If you compare it to the South America, for example, they have 30% only that the carbapenemase gene was not identified. So there's like a geographic distribution. You need really to know where do you stand. So do you have any data from Saudi Arabia? Actually, one of the center was from Riyadh, and they have we know that we have a 91 isolate included, 70% no carbamidase genes was identified. And if the carbamidase gene was identified, if you see the purple color, it's mainly VIM gene. Okay, so this tells us that, again, what we know before is that carbamidase gene is not the only or the commonest susceptibility, the commonest resistant mechanism. What I found interesting also that in this study is that the 30-day mortality was highest in the bloodstream infection. We expect that, but the most interesting is that the 30-day mortality was highest in Middle East. It's up to 29%. So 30-day mortality was higher in patients with carbamidase producing, actually carbamidase Pseudomonas organism compared to the non-carbamidase producing organism. And this is even after adjusting to the comorbidities, immune-compromised state, and the patient's the location of the infection. So this is interesting because it seems like having a carbamidase producing Pseudomonas put the patient at risk of higher mortality. Coming to this part, so I wanted to share this slide because it's interesting to know like if there is any difference between EUCAST and CLSI. We mainly use CLSI in our region. I believe most of the center using CLSI. But it was very interesting to see that EUCAST have a very low MIC for to label the beta-lactam, the first agent, the first line beta-lactam as susceptible. So for cefepime and ceftazidime, it needs to be less than 1 to be susceptible in EUCAST. While in CLSI, we still using 8. And the main difference here between the 2024 and 2022 is that they lowered the piperacillin tazobactam resistant MIC. So this is like interesting to see how there's like a difference between EUCAST and CLSI in terms of how to classify the Pseudomonas as susceptible to the first-line agent. Coming to aminoglycoside, I think there was a major difference in the last few years. So gentamicin is not anymore as an agent for to be tested for Pseudomonas. It was deleted from the CLSI, and for EUCAST, they said there is insufficient evidence. Coming to amikacin, CLSI will only report urine isolate to be susceptible or not. While tubramycin, it still can be reported from other than urine in the blood or sputum, but they again lower the MIC. So it's kind of like a war against aminoglycoside or something, but now we know that we have tubramycin is the only aminoglycoside that we can have an MIC from different samples. And I think this is like for clinical relevance, we used like the MIC, the antibiogram the year before to design our guidelines in, for example, febrile neutropenia protocol. So now you'll not be expecting to have gentamicin or amikacin, for example, from blood isolate. You'll only have the tubramycin MIC reported in your antibiogram. I'll just here focus on the colistin. I think it's very interesting to know that CLSI, there is no susceptibility category in CLSI. So the lab will just report if the MIC is equal or less than 2 to be considered as intermediate, while if it's more than 4, it's considered resistant. So no susceptible, like they will not tell you that this organism is susceptible. You just have intermediate or resistant. Coming to our new agents, so there is no much different. I just want to focus about. So I'm very glad to hear from Dr. Amrani that imipenem relebactam is promising with Pseudomonas because we are in a battle with a very strong like enemy. So imipenem relebactam, we have a MIC reported in EUCAST and CLSI, while with meropenem vaborbactam, it's only reported in EUCAST. We don't have MIC reported in CLSI. So I think I gave Dr. Qutb hard time when I came initially. It's like sometimes they reported cefepime susceptible and meropenem sensitive, meropenem resistant. And I will just, I call him and said, so we think with this pattern, it's sporine a mutation that it's collagen resistant, but can we make sure that there is no carbaminoase in this Pseudomonas? Because I want to use cefibim if I'm sure it's sporine, this is like a mechanism of resistance. And he said, Ghadir, we are not reporting any like this resistant mechanism. You just like you have the phenotype. And it's actually, this is what most of the centers do. So we expect from our microbiology lab to have, we don't expect most of the time carbaminoase testing for difficult to treat Pseudomonas, but then it's a must to have antimicrobial susceptibility testing even for novel agent. So for example, we have cefiderocol available, but then we have an issue that the testing for Pseudomonas is not available. Should I trust that as long as I have a new agent, our organism will be susceptible? I think after Dr. Amrani talk, no one will trust that. And and this is actually a very interesting unpublished data shared by Dr. Bilaji in ICMID during ICMID 2024. And you can see that there is a different MIC reported from FDA for susceptibility of cefiderocol. For FDA, it's equal or less than 1. For CLSI is equal or less than 4. So they tested 72 isolate for NDM Pseudomonas. Only 7% were susceptible to cefiderocol, which is scary, right? And in the best chance with CLSI, it's only 57%. I think the message is that if we want to use a new agent, is we have to have susceptibility test done while we are using that while we are using the novel agent, no matter how novel it is. So going to my favorite part of the talk, it's a controversy in the treatment of resistant Pseudomonas during clinical practice. And I'll start with this. So the case scenario is that this is a 24-year-old male, and he had a bacteremia with Pseudomonas that is susceptible to ceftazidime, cefibim, resistant to imipenem. So I want to know who's gonna go with cefibim as treatment. Who's gonna trust cefibim for treatment? Can you raise your hand, please? Anyone would use cefibim? Bacteremia with, this is not difficult to treat because it's susceptible to ceftazidime and cefibim, right? Anyone would trust cefibim? Oh, so Dr. Amrani and Dr. Mazin are trusting cefibim. Anyone would go with ceftolozine tazobactam? Who's gonna go with ceftolozine tazo? Again? Okay, so I really hope to bring any evidence to support the recommendations or to give guidance, but unfortunately there is no comparative effectiveness studies available to give. So this is like a kind of clinical. There is a guideline, the recommendations, which I think it makes so much sense. So for IGMA 2022, for non-severe low-risk infections, you can use the old antibiotics. Okay, this is the same actually with IDSA guideline 2023. So, but they actually give more like recommendation to in this regards. So if you have a carbapenem resistant Pseudomonas sensitive to cefibim, you can go with high dose extended infusion therapy of old agent. However, very important part is that to repeat your susceptibility test, or at least to make sure there is no wrong labeling in the lab or there is no wrong reading. And then if you trust the result, you can go with high dose extended diffusion. In a critically ill patient, you have an option to go for the novel agent because especially if you want to still to make sure of them the lab of the result. So this is an alternative approach is to go with novel agent. I think it makes sense to me that the recommendations in the clinical practice, when I have a patient that is really critically ill, maybe I'm gonna go with the novel agent. So, so this patient was started on ceftazidime avibactam, and this is like the organism that we have. It's fortunately susceptible to both agents. So who's gonna continue on ceftazidime avibactam? And who's gonna switch to ceftolozine tazobactam? Okay, so it's kind of equal voting. So actually, why do we trust ceftazidime tazobactam? I think this was also shared. We trust ceftazidime tazobactam more is because less prone to hydrolysis by MC and it's less likely to be affected by purine loss than ceftazidime. However, if we have susceptibility to both, we have to trust both, right? We have organism that is susceptible to both. What does the guideline says? So for the ICMID, the ceftazidime tazobactam is the drug of choice. For IDSA 2023, ceftazidime tazo, ceftazidime AV, and imipenem rilibactam are all options that you can have. For UTI, you can use cefidericol as well. And for infection that is outside UTI, cefidericol is an alternative, but it's not like the first option. I think from stewardship point of view, maybe going with ceftazidime tazobactam is kind of targeted therapy and narrower spectrum. But I mean, there is no at this point, I don't know what in the clinical practice I used to continue ceftazidime avibactam. If we have two agents, I'm not sure from stewardship point of view if switching to ceftazidime with ceftazidime tazobactam will make sense. Like it's a kind of de-escalation. So in case you don't have ceftazidime tazobactam and you continue your patient of ceftazidime avibactam, is there any change in the outcome? So I'm kind of proud to say that we have this data from Saudi Pharmacy Group. It was a multi-center study and they looked into the clinical outcome of patients who received ceftazidime avibactam versus ceftazidime tazobactam. And the clinical cure in hospital mortality and tertiary mortalities was comparable, actually. Despite that, they mentioned that 20% of patients who received ceftazidime tazobactam receive a suboptimal dose. And it's not uncommon to see. Sometimes patients in the ICU, they are using it by mistake, the dose will be they will receive suboptimal dosing. Coming to the combination therapy, so I'll just talk about carbapenem-resistant Pseudomonas. So to start with, I know this are you still talking about colistin meropenem after Dr. Omani talk? But I think considering that some of the centers, they don't have the novel agents. So what should I do if I don't have the novel agents? I think the first thing to do is to try to get one, right? And then if you cannot and you have a sick patient, one of the, I know that a lot of time we discuss OVERCOME and IDA trials, but then even in New England Journal of Medicine Evidence, they're still discussing that. So probably if you have a patient with Pseudomonas, you should remember that those studies were focusing mainly about the Acinetobacter pulmonale rather than Pseudomonas. Pseudomonas and CRE was accounted for less than 25% of the trial's pathogen. And both trials reported numerical reduction in 28 mortality with combination therapy compared to cholesterol alone. So if you don't have the novel agents, maybe try to get one. And if you don't not, and you have really critical patients, it's your clinical call to use that combination, I believe. Because one of the studies suggested that to go for further study. I think further study, maybe they will focus on novel agents rather than the combination. So if you're lucky enough to work in the center that has a ceftazidime tazobactam available, but then you have this organism, what you gonna do? I believe maybe you try to get imipenem rilibactam then, but if not available yet, I think one of the things that we might sometimes do in the clinical practice is trying to use ceftazidime avibactam plus styrinam. But this combination, we usually do it with CRE, with NDM, right? Do we use it, or is it effective really with Pseudomonas? I think so. There is in vitro suggested that it could be there is lowering of the MIC using this combination, but we have to go back to the resistant mechanism of Pseudomonas and remember that this organism is most likely due to a lot of mechanisms other than the carbapenem is producing. There is a lot of other mechanism of resistance going on. So I'm not really sure if this combination will save that patient. Maybe we have to go further for other novel agents rather than using this combination. And if you try to do that, maybe you can ask the lab to do the synergy test. Again, it will be difficult to interpret the result, but then maybe lowering MIC would kind of help, but it doesn't seem like it's a promising medication for difficult to treat Pseudomonas. My last part would be about how long is enough to treat Pseudomonas, and I think this is a kind of a lot of time we face this whenever we have a Pseudomonas bacteremia. 14 days to start from day one. They will decide to treat for 14 days. So for the bloodstream infection, we know that the famous RCT for the gram-negative, and we know that 7 days was non-inferior to 14 days. But then fewer patients were infected for Pseudomonas at that study. I believe it was like 24 or 20 in each arm. But we have a multi-center observational cohort study with uncomplicated Pseudomonas bacteremia who received a shorter course, 7 to 11 days were the definition of shorter course. And they have a similar odds of recurrence, infection, or death within 30 days compared to prolonged therapy with median of 16 days. I think when we are talking about duration, more than the antibiotic, we have other factors to play a role, mainly if there is line related to remove the line, if the patients have other things that we can control it and not just blame the duration for recurrence. So I'm transplant ID, I have to mention something about immunocompromise. So is short course antibiotic therapy suitable for Pseudomonas aeruginosa bloodstream infection in oncology hematology patients? I don't know how much I have time. 2 minutes? 3 minutes. Okay, so I have seen a patient who's like, unfortunately, she had a Pseudomonas bacteremia just 2 days prior to the recovery of her neutrophils. And it was line related. The line was removed and the bacteremia cleared. By day 7, she was not neutropenic anymore. Actually, she was like, her neutropenia recovered the second day after the Pseudomonas bacteremia. Line removed, repeated blood culture is negative. And she was staying in the hospital just to complete the 14 days. So by day 9, I discussed with the hematology that maybe it was just like it's enough. The repeated culture is negative, and she really looked well. She have an access to the hospital if she gonna have any symptoms. But he wasn't at all like impressed with that, and he wanted to continue 14 days. I think this is reasonable, but maybe we have more growing evidence that the selective patient, you can have a shorter course of antibiotic, even if your patient's in immune compromise. But remember that you have to control the other things, that if the line is the source, is to control it and remove it, and to have follow the patients for a few days before going to the shorter course. You can take a look on this interesting study, but this is some of the evidence growing in this very vulnerable population. So the short course was 7 to 11 days in the study, while and the long course was 12 to 21. Any patient who received less than 7 or more than 21 days of therapy were excluded. I'll not go through that, but I think like for treatment of pneumonia in VAB with Pseudomonas aeruginosa, the IDSA guidelines recommended 7 days. Still, some ICU wouldn't impress with this, and they want to go for longer duration. I think this study might have a contribution in that. One of the ICU actually consultant referred me to the study, and he said, we have a randomized control trial that's saying that 8 days is it failed to show an inferiority to 15 days. I think there's a lot of limitation in the studies, but you have to be aware of that, because this is like a controversy maybe with the other physician in your during practice. But at the end, I think the duration should be 7 days if your patient is really clinically well and there is no emphysema, or the clinical improvement happened early. But even ID, I think ID physician is still arguing about that. Actually. Thank you.